Thank you very much, Anne. And as someone who works for the Prevention Research Collaboration at Sydney University, I'm all about prevention. So it's very, very good to hear that word in any setting, particularly with a group of people involved with healthcare. So you've all been sitting for a while. So I want everyone to stand up, if you're able to. Just stand up for a couple of minutes while I introduce our panellists for the first panel session of the day. And just a reminder that while I'll be asking some questions up here, we really do want to hear from you in the audience as well. So when you sit back down in a moment to hear me ask the questions, you can just jump on the QR code, go to Slido and pop your questions in there as well. I would now like to welcome back to the stage Professor Matt Brown and Tiffany Boughtwood. Give them a round of applause. Come on up. Come on up. And we're now also going to have on our panel Associate Professor Azure Hermes. She's the Deputy Director of the National Centre for Indigenous Genomics at ANU. She's a proud Gimuy Walubara Yidinji woman, and we're so delighted that she's part of this event. I'm just going to come and join them over. Come and sit down, everybody. Over here. So let me tell you a bit more about Azure. So her focus is on building trust, supporting community decision-making and ensuring that tangible benefits flow back to the Indigenous communities involved. And during this panel, we're going to be exploring where we are in moving towards genomic-led care and make it the standard of care, like we heard, like it's going to be in the UK, so that more patients can benefit from accessible and affordable testing and treatment matching. And this is not the first time, if you've come to CanForum, that we've been talking about genomics care. It's been a major focus of CanForum, and it's been a really important part of rare cancers advocacy for the last couple of years. And as we've heard from Tiffany, the government has ambitions to really make genomic-led cancer care much more accessible. But we're going to be talking about where we're up to and is it enough, and will our current trajectory and approaches ensure that every patient, including First Nations patients, are included in that journey. So don't forget, pop your questions in Slido, and the questions will pop up here, we'll see them. You can also upvote other people's questions. So let me just get started. Matt, so I just want to go to you because your presentation was so interesting. I'm sure everyone in the audience will agree. It was fascinating to hear what's possible. But I'll just get you to share with the audience, when the UK first announced Genomics England, there were some bumps in the road in getting it going, wasn't there? And in particular, some opposition to where the genomic hubs were going to be. Can you talk a little bit about how you overcame that, and was it worth sort of getting through those initial bumps in the road to reach the milestones you've already reached?
Yeah, so certainly, as I said during my presentation, the setup for genomic services in England before the Genomic Medical Service was extremely fragmented. But the government took a decision that they were only going to fund a very limited number of laboratory hubs, and the decision was that ultimately there were 7 of those. And that took a lot of pain to actually close down or amalgamate different laboratory hubs around the place, just to come up with those 7 centralised facilities. It's not true that all genomic testing occurs in those 7 laboratory hubs, but the vast majority of it does. So there's still some specialised services that are provided outside of those. But given the efficiencies and high throughput of modern-day genomics technology and the challenges of the analysis and limited number of people who are able to actually do the reporting on these, I think that ultimately the community accepted that this was actually, from the public perspective, the right thing to do, even if it wasn't necessarily the right thing to do from the perspective of a small laboratory whose funding depended on that testing coming through. So undoubtedly it did lead to a lot of pain, but because you had people like David Cameron or Jeremy Hunt, the then Minister of Health, actually fronting up and insisting that this actually occur, those sorts of pressures were overcome, and it did actually eventuate.
So just before we move on to the other panellists, it was really clear from your presentation just how important that political leadership was in making these really significant advances. So what advice would you have for Australia in that respect? both with the political will and any other advice for us so that we can achieve some of what you've achieved in the UK?
Okay, look, I'm going to be very careful, having just had the Minister of Health and the Assistant Minister of Health come and present here. Obviously, you do have support. But what hasn't happened is basically really high-level public pronouncements about genomics as a relatively common feature of the discussion, and actual engagement and leadership in driving change from ministerial and prime ministerial levels to push it through. There is absolutely no way we'd have a genomic medical service if it hadn't been for the fact that David Cameron had a lived experience with a child with a rare disease and found that basically the whole system was basically not providing for his family situation and then thinking about everybody else. And that drove him to really push and make it a personal political agenda alongside devolution vote, Brexit and some other disasters. But nonetheless, he did get the Genomic Medical Service and the establishment of Genomics England absolutely right, and that has resulted in a really efficient world-leading organisation that wouldn't have happened unless he'd been there to do it.
So, Tiffany, when you see what's happened in the UK and you hear what Matt's saying, how feasible is it, do you think, that we could take a similar approach, or we could end up where the UK is?
I think the challenges we have, the NHS as responsible for delivery of healthcare, acknowledging the distributed and fragmented lab delivery, of course, but overlaid with Australia's healthcare system with shared responsibility with the states and territories, does mean that it's more of a process of negotiation. It's determining who has the means and the right to make decisions about different models of healthcare. So that does make it a more complex negotiation than perhaps political will driven by David Cameron with his child with epilepsy.
And for you, what does equity look like in genomics-led care for Aboriginal and Torres Strait Islander people, and how far away are we from achieving anything like that?
Yeah, so very far away, I would say. I have worked 10 years now with Aboriginal communities talking about genomics and trying to build knowledge and understanding and trust with communities to participate in this science. I can tell you that First Nations people feel like the most overrepresented, population when it comes to research. We feel like we've been researched to death. But when it comes to genomics, we're actually one of the most underrepresented populations within these data sets. So equity to me is to actually have more Aboriginal and Torres Strait Islander people participating in research when it comes to genomics. But it also means looking at some of the really big systemic issues that are currently facing our Indigenous populations in why they not want to participate in this research, and really addressing those issues and making sure that they feel culturally safe when participating.
And we've got some questions coming in from the audience, so I'm going to prioritise those as well as all the ones I've got. And the first one's for Tiffany, saying, how will Genomics Australia make public funding of genomic profiling for every individual with cancer diagnosis a priority?
So I think, and I was actually having a chat with a friend, Mark Buzzer, before the session today. Eventually, we would like to get to the point that, as Genomics England and NHS England Genomic Medicine Service have announced, that comprehensive genomic profiling, be it, a TSO500, a large comprehensive panel, or leveraging other genomic interventions, is standard of care for every patient that's diagnosed. But we're a long way off that aim where we are currently. And, I think we need to identify priority populations in patients, ones who have, the lowest sort of means of accessing now, or the potential greatest clinical utility of comprehensive genomic profiling. I think people with rare and less common cancers, cancers of unknown primary, are certainly within those subsets of populations that we can really demonstrate not only clinical utility, but also stress the system enough to start managing the genomic testing and the downstream care without overstretching it by going to every patient right now. And I think that approach of expanding the system and expanding the offering over time will be important.
And I might just ask Matt about obviously this transformation in the UK must have been quite a a huge influx of funds to make it possible. How much money overall did the NHS have to shell out to realise this vision? Just so we can sort of put it in context.
I don't know that anybody has a single figure on that.
No.
Right.
But it's clearly, as you say, quite large. And as I emphasised, it's been large and stable. And so that
stable in terms of the ongoing
year by
funding.
Year and multi-year programs of funding. So the program, the current spending review program, which basically gives us funding certainty out till 2030. And those programs are usually defined well in advance of programs actually finishing, so you know in advance that that's going to go forward. So it isn't a cheap thing to do. I mentioned the figure of $650 million to Genomics England. Half of that is the whole genome sequencing service sequencing cost. But when you consider that only 10% of cancer sequencing is whole genome sequencing, and that is actually only the sequencing cost and not the other costs associated with running a genomic medical service, you can see the scale that we're talking about.
Definitely. And Tiffany, I might just ask you, because we have lots of patients and patient advocate groups in the room today, what role are patient and health advocates playing in improving access to genomic testing? Because there still seems to be some confusion. You know, patients might be told that genomic testing isn't for them, or they're confused about their options. And I have to share the example of my own friend Helen. When I went with her to her oncologist appointment, and of course I went with my massive list of questions, and one of them was, can we sequence her tumour? And that was, if I hadn't have raised it, that would not have been raised in that consultation.
Yes.
And so I just happened to be the person asking the hard questions. So.
Yeah. Look, I think, advocacy by patient support and advocacy organisations, but also, it's the challenges of individuals having to advocate for their own care is really something we need to overcome collectively. I think advocacy and ensuring patient voices are informing policy, informing our priorities within Genomics Australia, and our discussions with the states and territories is part of it. But also, and I think this came up in discussion at our last CanForum panel, the amazing advocates we're seeing presenting today and sharing their stories as people with lived experience and carers. They're intelligent and eloquent and share their stories so genuinely and passionately, and it touches all of us. And I'm always conscious of those who can't self-advocate. People for whom language is not, English is not their first language or second or third. And how are their voices heard, and how are they informing the directions we're going and the priorities we're placing on genomic healthcare for people with cancers? And this is where Azure's work is so critical, because it is engaging with those communities and voices and developing resources to support their engagement with clinical research and clinical service delivery.
So Azure, from your work, do Indigenous Australians feel comfortable or confident in advocating for themselves and having those conversations?
It's been really interesting working. I work a lot with remote Indigenous communities where English is third, fourth or fifth language spoken. And the information we're receiving from communities who are accessing genetic counsellors and clinicians for rare disease or rare cancers is that they don't feel culturally safe in those appointments, that there are no culturally appropriate materials available for them to be able to make decisions that are best for them and their family and their communities. And we had some people even tell us that they would disengage with services because they just didn't feel like it was a service for them. They're also dealing with cultural aspects of that. There's shame and blame around why somebody has a rare disease or a rare cancer, and they have to look at the cultural reasons why that person might have that, and that's a little bit scary for them. So it's been really kind of interesting and quite sad to sort of see people withdraw from those services. But also there's this kind of willingness to want to participate, wanting to make sure that other families don't ever go through, I guess, the pain and the trauma that they have when they've accessed these services. And so we've got a lot of patients and we've got a lot of carers coming together now, wanting to develop resources, wanting to work with clinicians and counsellors in building training modules so that they're able to I guess, build better relationships with First Nations people when they're turning up for those very first appointments. So it is tricky for our communities, but there's this willingness to work with advocacy agencies to do better and to make sure First Nations people are included.
So I was going to ask you, Azure, whether there are any examples of culturally safe, community-led approaches to genomics that we could potentially learn from and scale up. That, you know, is there anything that is working?
Here's what I prepared earlier.
Yes, funny you should ask that. So for the last 2.5 years, almost 3 years, the National Centre for Indigenous Genomics has been working with advocacy agencies, Indigenous communities, advocacy agencies, clinicians and counsellors to actually develop culturally appropriate resources that community members and clinicians and counsellors can use at time of diagnosis. So those resources, there's a suite of resources, include things around looking at terminology, so chromosomes, DNA, variants, all those sorts of different things, doing a deep dive into what DNA is, learning more about research and what clinicians are. There's frequently asked questions, there's live interviews with genetic counsellors, all sorts of bits and pieces for people to use. And we're very lucky to receive some funding from Australian Genomics to build those resources, but now they are getting translated into the 5 top Indigenous languages spoken here in Australia, with the hopes that we can extend that for another 10 or 15 languages. So
that's fantastic. That's great to hear. So we've got another question from the audience, so I'll just ask that one, probably to Tiffany, I think. It says, increased testing is only part of the solution. The risk is that more patients would be told they have a rare cancer, resulting in greater emotional and financial burden if the precision medicine that they need isn't funded. How can we bridge that gap, Tiffany?
Yeah, thanks. That's an easy one.
It's not an easy one.
Look, I think the Minister certainly touched on that in his presentation to us as well. I think we're certainly conscious that testing is not the be-all and end-all, although it's, certainly my strength and background. I think working with Xero and Omico to understand that more extensive service that they're currently providing for patients, and understanding, what part remains in that translational research space, and how do we best equip and support the downstream activities that will inform access to therapies. And then, ongoingly, it's getting, as the Minister touched on, it's seeing the response to the HTA review. It's understanding how access to, sort of more pan-tumour drugs can be made available. But that's, an ongoing piece of work with PBAC and the department and the Minister.
So we've got about 5 minutes left, so just hop on the Slido if you do have a question for our panel, but I've got a few more I can keep going with. So we know that the research case is strong for how useful this approach is, but I'm interested in asking all of you, what do you see as the biggest barriers to making genomic testing sort of standard practice for all cancer patients, like it is with the Xero? Obviously we're doing it for children and young adults now, which is fantastic. How do we expand that out to everybody, and what are the barriers that we need to really address to make that a reality? Azure, from Indigenous, and then we can...
Yeah, for sure. So I think, not to do a funding grab here, but really it's money. Centres like the National Centre for Indigenous Genomics are doing everything from education, community engagement, pharmacogenomics, precision medicine. We're trying to build resources, capacity building. We have very few people working within this space. We're building trust with communities. We're trying to bring people along and to make them believe in this science as much as we do. And we do all of that by grant funding. And we receive very little funding from the ANU to be able to run the service that we do. Everything is through MRFF funding and NHMRC funding, so very target-specific grants that we have to look at for a short period of time. So in order for us to do the work that we need to do and to work with our Aboriginal communities and our Aboriginal and Torres Strait Islander communities and to get them into trusting this service requires ongoing funding and substantial funding, and we can't do it without it.
And Matt, what do you think to move Australia to that that goal of making genomic testing standard practice for all cancer patients rather than something that people are lucky enough to get if they can advocate for themselves or know the right people to speak to?
All right, so Azure's mentioned the issues around equity, and I'll step aside on that one, and just particularly focus on just scale. Mm-hmm. The scale required is really large, and so in the UK there are around 700,000 large panels or whole genomes for cancer alone tested per annum in England, for a population that's roughly double Australia's. And I think to do that you need to have a really efficient, large-scale, coordinated program to be able to do it. Tiffany mentioned the difficulty between states and federal. I think that's something that absolutely has to be negotiated, in that patients, people with lived experience, cancer clinicians and the community absolutely need to be pushing our politicians to get together to provide that sort of solution, because the current fragmented solution will never be able to provide that sort of national scale, which is only going to get bigger because as we head towards, as I mentioned, for example, cancer personalised vaccines, that's going to require everyone with cancer pretty much to have large-scale profiling, exomes, genomes probably, plus a transcriptome. And for England, that's going to be a challenge. For Australia, it's just science fiction at the moment. Yep. So I'd come back to, it needs a really large-scale, coordinated, stable, well-funded system to be able to do it.
And so, Matt, you mentioned funding, and there's just been another question pop in saying that there was about $1 billion in funding in genomics in the UK. How does this stack up if we're thinking about the $30 million that Genomics Australia has got? It's a substantial gap, isn't it?
Okay, I think I'm being slightly verbaled on the $1 billion figure.
Okay.
So what I would say is that I think $30 million is enough if what you're planning to do is policy development. Mm-hmm. But if you're actually planning on rolling out a proper national genomic medical system, it's completely inadequate. It's inadequate by a couple of log orders. And so it's a serious commitment to developing policy, but it's not a serious commitment to developing a genomic medical system.
Yeah, and there was no suggestion that $30 million was going to cover all the testing and all the downstream services, which was probably more along the sequencing itself, etc. Yeah.
So Tiffany, just so what would you see as the next step? So we're setting your role as setting up the systems and looking at what needs to happen, and then we would need
and then it would be going back to put in budget requests for programmatic funding for different, putting options forward for how to progress genomic programs, negotiating with the states and territories about appropriate funding models, considering the data piece that is so prevalent in its personal report now. So our focus is the policy, but we'll certainly be working with patient communities and the sector to work out how that policy becomes practice.
Fantastic. Look, we're almost out of time. I just want to go through to each of the panellists just if they have one last thing they'd like to say before we wrap up. Matt, one last message for the audience.
Well, I think genomics can be transformational for cancer care, and I'm delighted to see so much attention being given to it from the cancer community.
And Azure?
I'd just say that First Nations Australian are really interested in being a part of this. We have high populations of people who are dying from cancers and kidney disease and diabetes and all sorts of things. But please just include us in the decision making that you make about us. We want to be a part of it, but we want to make decisions too.
Mm. And Tiffany,
we are over. I think mainly my call is just please, we need to hear from you. We're keen to be informed by your perspectives. So please engage with Genomics Australia because, that is fundamentally my role. So
pick up the phone. Well, I'm sure you'll be getting a lot of calls after today and emails, but we're very glad to have all of our awesome panel here. Please give them a big round of applause. Thank you so much. I'll just get you to stay. We'll just stay put. So it's been a big start to the day. Lots of great ideas to make cancer care really personal and how we can really utilise genomics. We're going to have a break for lunch. These bells are not for us. You don't need to worry. It's not a fire drill or anything. We can stay and have lunch. We're going to be serving lunch at the back of the room. And when you hear our bell will be sounding at 12:45, that's the time to come back to your seats, and we're going to restart at 10 to 1. So thank you very much, and we'll see you then.